So abnormal bleeding can happen before and after your menopause. Before your menopause, abnormal bleeding would be bleeding in between your periods or bleeding after intercourse. After the menopause, you shouldn't really bleed at all unless you're on cyclical HRT, and then you should bleed at the prescribed time in the month when you're expecting it. So I guess abnormal bleeding is any bleeding after the menopause if you're not on HRT, bleeding on HRT at a funny time, or before your menopause, bleeding in between periods or after intercourse. So during menopause, you should see a doctor if you bleed after you've had more than a year of not bleeding, which is the definition, in fact, of menopause. If you get bleeding after your menopause, you should definitely see a doctor as soon as you can. If you've recently started on HRT, bleeding in the first 3 to 6 months is not uncommon, and this needn't be a problem. So you may wish to defer seeing your GP when you first start on HRT if you bleed. So in the perimenopause, which is the transition from regular periods to no periods, you may get abnormal bleeding because your ovaries progressively, if you like, malfunction, and the signals they send to the womb to bleed will become irregular, and the womb will follow that lead. So the ovaries in a way dictate when we bleed. So in the menopause transition, if the ovaries are sending messages to bleed, then your womb will respond. So it's not, so those hormonal changes will cause abnormal bleeding. After the menopause, which we define as 12 months without a period, you shouldn't bleed at all in theory. So after that time, if you get bleeding, then you do need to present because those will likely to be structural causes for abnormal bleeding as opposed to hormonal bleeding. When you have abnormal bleeding, the first thing we'll do is take history and examine you. We'll examine you to check that you don't have any abnormality of your cervix, for instance, that needs a follow-up smear or colposcopy. We'll check for polyps, and then we'll look higher up into the womb. We may take a biopsy from the womb lining, but we'll almost certainly do an ultrasound of the womb lining to check the thickness of the womb lining. If it's thickened, either generally thickened or it's thickened because you have a polyp, then you'll need to go forward to have a hysteroscopy to have a look at the pathology inside the womb directly with a telescope. This is a procedure we can do either with you awake or asleep. A telescope's passed through the vagina, through the cervix, up into the womb, and we can examine under direct vision the uterine cavity. I have techniques called Marshall, which enabled me to under direct vision, remove polyps or fibroids in the cavity. And this can then be sent to the laboratory for investigation, for histology. The other tests I guess we may do if you've got abnormal bleeding might be blood tests, depending on the heaviness of the bleeding. And we may in some situations look at your hormones to see whether the bleeding's hormonal. So endometrial hyperplasia is a condition where the womb lining is abnormally thickened. It's commonly seen as a precursor to endometrial cancer. There are two hormones that affect the womb lining: estrogen, which thickens the womb lining, and progesterone, or copies progestogens, which thin the womb lining. If the womb lining over-thickens, then hormonal treatments such as the Mirena coil or systemic progesterone or progestogens will help to thin it. In addition to this, you'll need to have your womb lining examined hysteroscopically and biopsied at various intervals. Moving forward to vaginal atrophy, that's a really important area, and we haven't really touched on that yet. This is where the vaginal wall is very thin because it has low estrogen. And sometimes after the menopause, if you've not used HRT particularly if you haven't used vaginal HRT, the vaginal wall can be very thin. And sometimes this can become so thin that it weeps and bleeds a little bit. The treatment for that is vaginal estrogen. We have lots of different forms of vaginal estrogen. It's a homeopathic amount a whole year of vaginal estrogen is about the same as 1 day of systemic HRT. So you don't need to worry about risks from it or systemic absorption. And it's really effective at treating vaginal atrophy. It'll make the vagina more comfortable, it'll improve the biome in the vagina, it'll decrease your risks for urinary tract infection, and it helps the bladder function too. If your bladder's irritable, maybe if you're getting up at night to pee, it might improve that. So vaginal estrogen is a really, really good treatment for vaginal atrophy and the problems associated with low estrogen.